Hi, my name is Mike McMillan. I'm a nurse anesthetist here at Moses Cone. I have 18 years experience as an anesthetist. I've also got a background in emergency nursing. I worked downtown Philadelphia permanent night shift for a number of years, and I also worked out on the street as a paramedic in Montgomery County, Pennsylvania. Today we're going to talk about airway evaluation and provide a small management review. I always like to start out with a quick trivia question here. Arthur Goodell was the inventor of the endotracheal tube, and my quiz is always, what was the name of his dog? And I've only had a few people get this question right. But what Dr. Goodell used to do to promote his new device was he would take his dog, he would anesthetize his dog, put it in one of his magical tubes, and then immerse the dog in a large aquarium, and then bring the dog out after demonstrating how watertight the seal was on the airway. And that gives you the answer to the question. His dog's name was Airway. So initially when we talk about any airway, we want to evaluate the airway. What does the patient look like? Is he a young, healthy adult with a mouth that opens readily, or is he a big guy with a beard? Is the person very large? Do they have large breasts? Are they on a backboard with a C-collar? Do they have a thick neck? These are all the things you want to look at to anticipate whether you may have any difficulty with the airway. Because anticipation of needs is critical to what you're going to do to intervene in the airway. So when we evaluate the airway, we want them to open their mouth, give them say a big ah. You want to look at their tongue versus the pharyngeal size, how readily their mouth opens. If they have some severe TMJ, they may not be able to open their mouth much at all. Some connective tissue diseases will also decrease your mouth opening as well. You're also going to look at uvular visibility. You see on the left, you have that nice little dangle on the back of the throat. That's normal anatomy. And on the right, there's something missing there. This person has had a UPP. They've had a pharyngoplasty and uvulectomy. So there is no uvula present. If you look really close, you can see a black dot in the back of the airway, and that's a tattoo that demonstrates midline. And you can also note the large tongue and facial hair, so you might anticipate that you might have a little bit of difficulty with this airway. So we're also going to look at airway classifications. When they open that mouth, what do you see? Are you able to see that uvula completely, or do you only have a partial view of the uvula? When you have only a partial view of the uvula, that could indicate a more difficult airway as well. So in number one, we see that you can see the soft palate, the tonsillar pillars, and all of the uvula. Number two, the tongue hides the base of the pillars and part of the uvula. 3, you only see soft palate, and 4, you don't see anything. So 4 is a very difficult potential of airway. We're also going to look at how well their neck moves. We especially want to be attentive to the atlanto-occipital extension, how well they're able to go back. Sorry, I'm trying to do two things at once.
You're fine.
So this is a nice young healthy patient with a good atlanto-occipital extension. However, there's many people with severe arthritis, rheumatoid, any patient in a C-collar on a backboard, you're not going to be able to get atlanto-occipital extension. And that's what's going to help you align your axes for intubation and successful airway control. When you ask them to move their head back, does the whole body move, or just their chin move? Sometimes people will arch their shoulders back and they'll get their head back, but it's more from their back, not their atlanto-occipital joint, which is more important. So we also look at the thyromental distance. That's the distance from the notch of the thyroid cartilage to the bony prominence of the chin. The bony prominence of the chin is also called the mentum. Less than 6 centimeters is indicative of an increased difficulty. Usually that thyromental distance is much shorter in individuals with receding mandibles or thick necks. So if you don't see much of a chin, or you see a big burly neck, then you might have an indication that you may have difficulty. We also look at dentition. I'm sure we've all seen some of these mouths before. Some we want them not in our memory anymore. But you want to look for prominent incisors like that lady on the right. severe broken or decayed teeth, dental prosthetics like dentures. Sometimes you may go in there and find a denture with an unconscious patient the hard way, but the good news is you could remove it and you can get more room in the mouth. But on the antithesis of that is if we have an edentulous patient, they may be a little bit more difficult to manage with a bag mask because they lose that facial structure that helps form a good seal. You can see on this lady in the middle that you're going to get a lot of leakage around the side, so you really have to kind of tuck the tissues in there to get an adequate seal to ventilate. Besides just looking directly at the airway, we also want to look at diseases and comorbidities that may affect the airway. There are certain genetic abnormalities, such as Down syndrome, where they're going to have a thick neck, a very large tongue, may have some difficulty in moving their atlanto-occipital joint. Pierre-Robin, which is a congenital anomaly where there is basically no chin, very difficult airway potential, Turner syndrome, and other things. Also, infection may be a problem if they have peritonsil abscess, parotid infections, Ludwig's angina, where there could be some severe swelling in the airway itself or directly around the airway, compressing the airway structures. Also, head and neck cancers or masses, they may compress the airway structures as well, so you want to evaluate trachea for midline to see if there's any deviation and get a detailed history if you can. Anaphylaxis and angioedema are another severe, potentially fatal airway anomalies, so you need to be aware of what your causative factors are. Here's a slide. We look at the anatomy of the airway and the different structures. You can look at that on your own. I'm sure you've all seen these before. But it's good to visualize what the normal is supposed to be and where your structures are supposed to be and where you're supposed to be so that you're able to accommodate that for each of your patients. So this should be your most ideal view, and that's what we all like to see, some nice wide open vocal cords ready and waiting for us to put an endotracheal tube. And if you know the anatomy and the structures of what you're supposed to see, then that'll aid you when you don't have a clear view or if there's some distorted anatomy. So sometimes if there's some severe distortion of anatomy, you may just want to trace down on the structures that you can identify and know and follow those into where you think the vocal cord should be, and sometimes that will save you. So we look at the glottic opening here. You can see the uvula up top. You can see the vocal cords. You can see the arytenoid cartilages. A lot of times, if you don't see anything else, you just see those arytenoid cartilages or the base of them, and then you know exactly where you need to go and kind of just direct up with your endotracheal tube, and that'll help you out. So, like I said, once again, we're looking at the ideals. When we talk about positioning for the airway, we're looking at three different axes. We're looking at the oral axis, the pharyngeal axis, and then the tracheal axis. And when you can align those all up, like in diagram C, that's going to give you your most direct view. Every patient's different in how to get that direct view. If you have somebody with anterior cords, you may need to get them more in a sniffing position. You can see in the diagram of C, they have them pretty severely hyperextended. Hyperextension is great, but some patients that doesn't work out too well because if that axis doesn't line up, then it's not going to do you any good and it's actually going to obscure your airway more. So sometimes it's a little counterintuitive. You may need to add some extra padding underneath that head and put them in what they call the sniff position. So imagine you just kind of lean your head forward to sniff a flower. That's the kind of position you want to have when you're laying back flat, and that may assist you as well. So as you know, when we're positioning the laryngoscope blade, MAC blade, we're going to go into the molecular space like on the left. You indirectly move the epiglottis to allow yourself visualization of the glottic opening. And then at B, we're using the straight blade there, where you directly move the epiglottis out of the way. So two different techniques. One, you're going to slide along the base of the tongue into the molecular space, and then look for your 10 o'clock and pull upward and outward to the left to get your view. With the straight blade, some people like to go a little bit deeper and then slide back until the airway slides into view and drops into view. So once again, we talk about a grade view for assessing the airways. It's sort of like when we're looking in the airway itself. What do you see? Are you able to see the whole glottic opening and all the vocal cords and all the structures? Are you able to just see the arytenoid cartilages and the base of the glottic opening? Do you not see any opening at all and just see a trace view of the arytenoid cartilages? Or like in grade 4 where you really don't see anything, it's basically a blind intubation if you're able to get it in, and it's not a good view and not what you want to have. One of the things that we've used to kind of assist us in intubation is the glide scope.
I'm not sure this is gonna work on here.
Looks like it is working.
No. I'm wondering if we can pull it, if we can disconnect that long enough to be able to see, like zoom in on his screen here.
Yeah, sure.
Hello.
That's good.
We're gonna have to get a whole lot closer.
Yeah.
Sorry.
Into your personal space.
Ready?
Yeah.
Oh, are you still recording?
Mm-hmm.
Okay.
So here we are, we're opening the mouth, directing the glide scope into the oropharynx. Sliding down, you see the epiglottis. And the glide scope does fit into the vallecula here. We're getting a nice grade 2 view. You can see the arytenoid cartilages, you can see the glottic opening, and there you have your endotracheal tube going in. And that ideally is what you like to see every time you go in for an intubation. Okay.
You're gonna look back at this and laugh.
Well, like I said, you could always get me back in live if I have the time free. Because
And
everybody's gonna be like going,
I still would like to
"Whoa."
do that because I still think we need to add the sim lab with it, because that then brings in the ventilator and that kind of stuff
Okay.
with it, so, okay. You're good?
Yep.
We're back to you then.
All right. Well, one of the most important things that I want you to get out of this lecture is never underestimate the value of basic airway techniques. Most airways are manageable with basic airway techniques, and it'll buy you that time for an advanced airway, and it's always the bailout plan if your advanced airway does not work out. You always want to go into an airway and look at it. That's why we have you evaluate that airway ahead of time. If you don't think you're going to get it, and they still have a patent airway, then support them. Don't get in over your head and try an advanced airway when you have a lot of uncertainty and you can manage it in a basic fashion. When you can get to a more controlled setting, that's always the best. So when we talk about basic airway management, we're just using the bag valve mask with proper technique, utilizing your extra adjuncts such as oral or nasal airways when it's appropriate. If you have somebody with a significant gag, you don't want to use an oral airway, you're going to make them vomit and aspirate. Nasal airways, you always want to be cautious because of bleeding. Use additional resources when you need it. If you have a significantly obese patient, sometimes one person just holding that mask on with 2 hands under the angle of the jaw, 2 C's on that mask, and getting a nice tight seal while the other person actually does the ventilation could be a very effective technique when you get into difficulty. You always want to optimize your conditions for successful airway management. You always want a good mask seal with the least amount of pressure. Use your positioning. You can always reposition. Use your fingers under the angle of the jaw to kind of give a jaw thrust as you're masking. Use gravity to your advantage. Little reverse Trendelenburg or put them in a semi-sitting position, especially for larger people or women with large breasts. That'll help. Use gravity as your friend. Use of a shoulder roll or a pillow under the head to get a snip position. Big thing is you want to avoid gastric insufflation, so provide enough pressure that you're going to inflate the lungs, but you don't want to overpressure where you're going to end up just distending the abdomen. We also talk about for pediatrics, sometimes you want to get that grip and you don't want to put the kung fu grip on to the point where, you take the mask off and the kid's got bruising, circummoral bruising from, we call it the toilet seat. When you come off with a lot of redness or bruising around their face when you get done because you've gotten so happy about the ventilation. When we get into advanced airway techniques, we're talking about rapid sequence intubation, nasal intubations, needle crikes, use of the King airway, and other airway adjuncts. Like we said before committing yourself to any advanced airway technique, have a plan A, a plan B, and a plan C. Ask the questions, can I do this? What is your experience level? If you don't think you're able to do it, and there's nothing wrong with that, then don't. Use your basic techniques until you can get to more optimal resources. Do I have the resources to do this? Do I have all the equipment that I need to accomplish this successfully? Do I have, suction? Do I have all the equipment that I need to intubate? And what happens if I can't intubate? What if I can say, okay, I'm going to do a rapid sequence intubation, I have a problem, I can't see anything, I can't get that tube in. What do I do after that? So always have that in the back of your mind when you're seeking out these advanced airway techniques. There's the old expression of don't screw the pooch, so you always want to make sure that you don't get in over your head. A lot of times, especially in the medical profession, we tend to kind of take it as a personal affront when something doesn't go our way, and whether that's an airway, an IV, or whatever, and we have this attitude of I'm going to keep trying until I get it. However, when you do that with an airway, you can end up causing death, hypoxia, severe airway trauma, and you don't want to go there. Even under the most optimal resources, we have bailout plans and we say, enough, we're not doing this, or we need to go to a surgical airway. Also, when we talk about rapid sequence intubation, when you have a patient who has a blood pressure of 50, do they need drugs? Not really. They're not perfusing. There's no blood getting to their head. They don't need drugs. All you're going to do by giving a bunch of drugs, especially an induction agent, is finish the job. Your pressure of 50 is going to go to 0 very quickly. If you have somebody who's severely hypercarbic, they already have anesthesia on board. When your CO2 gets above 90, they're going to be uptunded. They're not going to remember. May seem sort of mean, but guess what? It's the safest possible thing to do is just to get that airway. And we talked about spray and play, which is where we'll maybe numb up the airway, give a little IV lidocaine, spray them up with some topical anesthetic, and then take that look with the blade and see where you can get. And if they bite down on you, don't put your fingers in there. But if they bite down, then okay, I need something to help me out. I can go with succinylcholine. I might go with a very low dose of induction agent, such as amidate or propofol. But if you can get in there and get the airway without having to give any drugs, all the better, because that's the safest plan possible. And that way you won't get in over your head. When we talk about rapid sequence intubation, always pre-oxygenate when you can, 100% oxygen. Utilize your cricoid pressure, have somebody holding that and not releasing that until after the tube is in place and you have confirmed its position. Administration of short-acting sedative hypnotics such as amidate at 0.2 milligrams per kilogram or propofol 2.5 milligrams per kilogram, along with short-acting neuromuscular blockers. Succinylcholine is optimal, 1.5 milligrams per kilogram. And you could also use rocuronium, which is a non-depolarizing agent in the case of burns or hyperkalemia, and you're going to deliver that at 1.2 milligrams per kilogram. You're not going to ventilate prior to your intubation attempt after you've given the drugs. So the idea is to hyperventilate, give them a little bit of reserve, induce, wait till they fasciculate if you're using succinylcholine, wait till you get some level of paralysis with the rocuronium, then attempt to intubate. Indications for rapid sequence is inability to maintain airway patency, the patient's inability to protect the airway from aspiration, any sort of ventilatory compromise, inadequate oxygenation, or anticipation of impending inability to maintain or protect the airway. So when we talk about anticipation of impending inability to maintain or protect the airway, we're talking about a worsening situation where, such as swelling, in the case of anaphylaxis, angioedema, trauma, where they may be bleeding from their neck or expanding hematoma in their neck, any of those things that may totally occlude your airway if you don't act. Complications of intubation. You're looking at dental or soft tissue trauma, retropharyngeal perforation, aspiration, inability to secure airway and failure to ventilate, and subsequent hypoxia, and you can also cause bleeding. So when you get to the OR and you come to see us for your intubations, we always need to look at the complications of intubation. This is not an emergent situation for the most part where you have to get an airway in at all costs. Usually, as is the case for routine surgeries and, where people have come in, they pay their money, they don't want to come out with missing a tooth, they don't want to come out with a cut lip, they don't want to come out with a retropharyngeal perforation and subsequent sepsis, they don't want to aspirate, and they don't want us to lose their airway. So we're going to be a little bit fussy in how we direct your technique because of that. So if we see you're on a lip, then we're going to direct you to refine your technique. If we see you near the teeth, we're going to remind you to kind of not rock back and definitely look for that 10 o'clock position. And we're also going to kind of take over the helm if we see you're having difficulty. So don't take that as an offense. It's just, we need to protect our patients first. Also for intubation, nasal intubation, it's usually not the technique of choice. The gold standard is an oral intubation, primarily because we worry about bleeding and risking further airway compromise. The only thing nice about nasal intubation is it can be done blindly, and it can be performed on patients who are spontaneously breathing, at least in the case where you don't have hypercarbia being your friend in anesthetizing the patient. So we want to have lots of lubricant, maybe use of sequential nasopharyngeal airways, and utilization of a BAM valve. I don't know if you all are familiar with that. It's a small whistle that fits on the end of the endotracheal tube and makes a different tone for inspiration and expiration. You always want to direct your tube through the glottic opening when you hear that whistle loud and you hear the inspiratory whistle. And that'll help you get into place. Usually we talk about the Hulk Hogan headlock technique for putting in the nasal tube. You kind of wrap your arm around the patient's head with one arm to keep them stable, and then the other one sliding and easing the tube down into the glottis. Use of the King airway. I know this is a popular one for the street. It's not a technique of choice for managing the airway. There's very high risk of aspiration when changing them out. The only good thing about it is it's a blind insertion, but there can be a delay in oxygenation while confirming, depending on whether you've ended up in the trachea or in the esophagus. I've had personal experience with the King airways, changing them out because they have to be deflated before you can withdraw them, and you can't get a laryngoscopy view. The result is if they have had some abdominal insufflation, like when you're testing to see where you are, and they've had a couple big bags fulls through the King airway into the esophagus, then all of a sudden you have a lot coming back out to where you're trying to establish an endotracheal tube. And finally, one of our bailout methods is the needle cricothyrotomy. We're looking at the cricothyroid cartilage, which is right. I'm gonna go back here.
Yeah.
So you're looking right into this space here is where you want to be. So right below the thyroid cartilage, right above the cricoid ring. So you can always palpate your own cricoid cartilage and thyroid cartilage and find your cricothyroid membrane. Remember that this is the airway of last result. Prep the area. You're going to insert a needle through the membrane at a 90-degree angle until air is aspirated, and then direct the needle up toward the head and advance the catheter. The quick and dirty method is using a large bore angiocath, 10 gauge to 14 gauge, and you use the 3mm adapter off an endotracheal tube and bag through that, or you have the larger cricothyrotomy kits, which actually get you up to a 6mm diameter, which is kind of nice. Use of jet ventilation is preferable for the smaller airways, like if you're using an angiocath. You'll be able to deliver a fair amount of oxygenation. However, you're not going to get a lot of release of your carbon dioxide. There's a spiraling effect that takes place when you use jet ventilation, and that carbon dioxide relief is passive and it takes some time. So they are going to retain CO2. One of the things with the use of a needle cric that can happen as more of an advanced technique is we could also pass a wire up through that angiocath up into the oropharynx, retrieve that wire in the oropharynx, and then pass a tube down that wire and into the trachea and down through. Other adjuncts you could use are a bougie stylet. Lighted stylets are trigger tubes. With the bougie stylet, you need to be able to see the glottic opening. If you can't see it, then you really can't use it. It's for the situations where you can see the glottic opening, but you can't angle your tube or direct the tube into the glottic opening. So pass the bougie in first, and then take an unstyleted endotracheal tube and slide it down and over while you're directly visualizing the glottis. Lighted stylets need a lot of practice to use it for it to be effective, so you need a lot of time in the lab. Some people love them if they're experienced with it, but it's not a regular technique, so it may be a little bit more difficult to adapt. I've only done it twice, and I wouldn't feel comfortable trying to do a difficult airway with it, but some people swear by it. Trigger tubes, regular endotracheal tube that has a little ring that you can pull on, and it will angle the tip of your endotracheal tube in an upward fashion and get you into more of a hockey stick position to help you direct the tip of the endotracheal tube into the glottic opening. Other airway adjuncts that we don't use on the street, but we use in the OR and other areas of the hospital are the LMA, which is a laryngeal mask airway, which is a supraglottic airway. It sits above the glottic opening. It's not as secure as an endotracheal tube. However, it's good in patients where you can't intubate directly, and it'll buy you time. We can also do people with, hold on for a second. I'm gonna get tongue-tied here.
Push the off button.